Okay, so we're going to go over hypothermia protocol. And so if you look at return of spontaneous circulation, then you see, is there a STEMI after a code, right? If there's a STEMI, then boom, you're going to go to the cath lab, right? If the patient follows commands, you obviously don't do targeted temperature management. But if he's or she's comatose, then typically we think of 32 to 36 degrees for 24 hours, right? But we'll see if that's really evidence-based. So mechanisms of hypothermia, neuroprotection, brain metabolism, attenuation of neurotoxic cascade, abolition of reactive oxygen species, many different mechanisms you could think of. Here, our protocol inclusion criteria is pulseless less than 60 minutes, return of spontaneous circulation, obviously, less than 6 hours past. It's VFib or PA or asystolic arrest in our criteria. We'll look at the evidence behind all these things. Exclusion criteria, potentially pregnant patients shouldn't make sense. Why necessarily? Sedation and analgesia. When they're on hypothermia, Versed drip, fentanyl drip. Sometimes we don't want them shivering because then they will heat up faster, right? So we might do some neuromuscular blockade if that's the case. So what is the criteria? What is the evidence? So we have the HACA study in 2002, 32 to 34 degrees out of hospital VFib cardiac arrest for 24 hours. And the number of cases, this 96% of them were VFib. So it was really a VFib study or pulseless VTAC. And it basically showed an improvement if you were hypothermic in terms of survival compared to normothermia. That's the HACA study group. February 2002, favorable neurologic outcome, about 40% in the normothermia, but 55% if you were hypothermic. So not only death improvement, but a favorable neurologic outcome, which is defined as cerebral performance category of 1 or 2, which is good recovery or just moderate disability. 2002, the same day, they had a smaller study, 33 degrees for only 12 hours, not 24 hours, within 2 hours of return to circulation. And essentially, it also showed, it wasn't as impressive, but people that were in the hypothermia had normal or more likely to be normal or minimal disability. But the first trial is the more impressive one, the HACA trial. And then you have this TTM trial in 2013. I'm just looking at the randomized controlled trials. 36 is just as good as 33 for 28 hours. Within 6 hours of return to circulation. Basically, again, we're looking at mostly VFib patients, 75%, non-perfusing VTAC, only 3%. So a shockable rhythm for the most part in that trial. And it did not show an improvement. Again, this was 36 versus 33. So that's where we started changing and going back to 36, saying that that's just as good as 33. The primary outcome was the same in terms of deaths at the end of the trial, about 50%. And neurologic outcome, CPC, the same as well. And then in the editorial, they said, how come there's such a difference? Because in contrast to a decade ago, 1/2 instead of 1/3 of patients with return of circulation can expect to survive the hospitalization. I don't think that's what that the evidence really showed. So I don't know where they got that. But in any event, then in 2019, you have this trial, targeted temperature management for cardiac arrest with non-shockable rhythm, which is basically the Hyperion trial, which is 33 versus 37 degrees in out-of-hospital non-shockable cardiac arrest. This is the only trial that actually randomized trial that had in-hospital patients as well. And that's for 24 hours. So now the difference here is that we're looking at asystolic arrest, PA arrest for the most part. And So that's pretty incredible that now we're switching gears and looking at that. Of course, the mortality in that patient population is much lower than the VFib-RS, pulseless VTAC. So you can see the CPP score of 1 or 2 was only 5.7% in normothermia, but 10.2% in the hypothermia. That's a significant difference. Better if you were basically 33 degrees than 37 degrees in a non-shockable rhythm. The 2020 AHA guidelines basically say you should do TTM for all patients who do not follow commands. We could see level 1 evidence here. We recommend selecting and maintaining constant temperature between 32 and 36 degrees, and it's reasonable to do that for at least 24 hours. They also recommend doing this for both non-shockable and shockable rhythms, despite the finding that 33 was, basically just as good as 36. That was saying still 36 is good. That was TTM1. And then the Hyperion basically showed that the non-shockable rhythm, there's a benefit. But now we have TTM2, which is this trial in 2021, after the 2020 guidelines at AHA, hypothermia versus normothermia, out of hospital cardiac arrest, 37 as good as 33 in VFib plus asystolic cardiac arrest. This time it's even more evenly. Shockable rhythm, 72%, but 30% was non-shockable. You can see that there was no difference between hypothermia and normothermia, even in the subgroup analysis when you break them down, non-shockable and shockable, and age-wise, time of resuscitation to return to circulation. Essentially, it was again 50% primary outcome death, hypothermia, normothermia, no significant difference. So let's review the trials again. We have the HACA trial over here. Then we had TTM1, which basically said 33 was just as good as 36. Then we had the Hyperion with the non-shockable rhythms. Then we had TTM2, which basically said 37 is as good as 33. That's not saying too much about doing hypothermia protocol in the patients that have those cardiac arrest. Then intensive care medicine did a systemic analysis, meta-analysis, and basically said mild, moderate, or deep hypothermia may not improve survival or functional outcome after out-of-hospital cardiac arrest. And there was a higher incidence of arrhythmia. So that sets the stage for the newest guidelines, which is the European guidelines on temperature control after cardiac arrest in adults. And essentially they say, we recommend preventing fever for at least 72 hours post-cardiac arrest. And then they say there's insufficient evidence to recommend for or against temperature control of 32 to 36, but they don't want to do active rewarming comatose patients with mild hypothermia. So we don't say we should rewarm them, but we don't have to cool them down for 32 to 36. You might want to do 37, that makes sense, with preventing fever, but again, that's not even proven. That's the next study, 37, I guess. But also this preventing fever for 72 hours, we just have a newest study, which showed, how long should we keep these patients fever-free after cardiac arrest? And it turns out that 36 hours total means 12 hours after the initial protocol is just as good as 72 hours. So you don't need to do 3 days. This was studied in a bunch of shockable rhythms, mostly shockable rhythms. And there was no difference in terms of survival if you did temperature control for 72 hours versus 36 hours. So basically, a day and a half of temperature control is just as good as 3 days of temperature control. So let's go over this, which is mismatched. HACA, 33 for 24 hours. TTM, mostly shockable rhythms. Hyperion, mostly PA and included IHCA patients. The one that's mismatched is actually Hyperion because it's mostly asystole. And it's also the first randomized trial. How about the 2020 AHA guidelines? Recommend 32 to 36 for 24 hours in which rhythms and for which cardiac arrest? So they recommend for both shockable and non-shockable rhythms for both OHCA and IHCA. How does the European Resuscitation Council differ from the AHA guidelines? They don't recommend 32 to 36, just prevent 37.5. Does preventing fever for 72 hours post-cardiac arrest improve survival compared with just 36? Doesn't show improved survival. What's the real takeaway? Probably avoid fever for 36 hours. I would probably shoot for 30, at least 36, maybe 33 in the asystolic arrest, and I wouldn't prognosticate before 72 hours. Thank you very much. Thanks for listening.